So, can you briefly share your journey from medical training to building a private medical practice?
I'm sure. I mean, after 5 years at the med school, like any doctor, some people do six. I did my house officer year, what it used to be called, when we're doctors with L plates before the GMC takes us on. And that was all, I did that all in one place, actually, at the Homerton Hospital in Hackney, which is a great hospital, now calls itself a university hospital. Unusually, actually, because I went to medical school with the intention of becoming I knew very early on that that's what I wanted to do. And what used to be an opportunity, things have changed a great deal now, as old as I now am. You used to have to do 6 months general surgery, 6 months general medicine, and that's what was necessary for you to gain your registration. But there were what were called 12-month jobs, gave you the opportunity to spend 4 months in each of those, with the opportunity to spend 4 months working in a separate medical specialty. And there was the availability at Homerton to spend 12 months solidly there, rather than moving to another and doing 4 months of medicine and surgery and 4 months of psychiatry. So I did that between my medicine and surgical jobs, and it was overall, it was a pretty fantastic year. It's a brilliant hospital in which to work in, and really kind of harness the collegiate spirit that I think that actually doctors come to appreciate a very great deal in terms of what they do in clinical practice. I then took a bit of a U-turn because I took a bit of a sort of an unusual turn, because I went off to Egypt to work in hyperbaric. Love the diving, and again, things that I think quite restricted these days. But when I graduated, a medical degree was this incredibly useful thing to have, because it enabled you to do so many different things without pegging yourself into a particular corner and painting yourself in a particular light. So I spent time in Egypt working in hyperbaric medicine, which was fantastic. The weather was certainly a lot better than I was there in the autumn and early winter. And before I returned to a CAS officer job, which is as a senior house officer in the emergency department. And I was working at the Homerton, but I spent 3 months there and 3 months at the Royal London Hospital. And back in those days, it was the only hospital that had the we had the only helipad in London, at any rate. So I was working directly with the trauma team as well as a CAS officer. I was allowed to get my fingers on that. And I think to date, actually, that was probably one of the most enjoyable jobs I ever did, just because it has such a steep learning curve. And as a junior doctor, by and large, you kind of fall into the routine and the mechanics of a job quite quickly, because the rudiments need to be learned, but they're relatively straightforward. And once you've got them down, you've got them down. Whereas working in A&E, you never know what's going to come through the door. And we were there during the SARS pandemic, which it feels small to us these days after the event of 2020, but nevertheless, it was the big concern at the time. Anytime anybody came into the hospital with a fever. And then I applied for my psychiatric training rotation, and I was due to start straight after my emergency medicine job. But I've always been very interested in neurology, and my general feeling, I think at the time, a little didactically, was the fact that I became convinced that anybody becoming a psychiatrist would have to train in neurology as well, which I don't think is true now, I have to say. But for my purposes, it was undoubtedly necessary and beneficial, and I managed to obtain a job as a clinical fellow, again at the Royal London Hospital, who have had for a long time a major clinical neurosciences department, neurology and neurosurgery, and obviously with access to the trauma service as a consequence of the helicopter, it meant there was an awful lot that used to come through the doors, and we were a major clinical neuroscience centre that would often then transfer patients on after acute care to continuing care and rehabilitation at other hospitals. And that was a fantastic job, because it meant that I was working directly on the neurosurgical side as well as the neurology side, but it meant that my exposure to neurological conditions was vast and varied. I had a series of consultants for whom I was working, and they all had different and varied interests, and it meant that my exposure to different disorders in the outpatients clinic, but also on the wards, meant that I was able to see things, clinically examine patients and understand their conditions and their treatment in a way that actually sitting exams and studying textbooks without saying these things would never have sufficed. So then following that, I started my psychiatric rotation, which was all based in East London, which was a marvellous training experience for me, and speaking to people who trained elsewhere in the country, particularly outside of London. The extent and the concentration of what I was exposed to on a day-to-day basis was huge, and I think still is. I mean, the number of consultants now working in that part of the world has absolutely exploded since I was there, because of the demand, because of the need, because of the morbidity in that particular part of the world. So that was a great training experience. I sat the first part of the membership exam for the physicians, the MRCP exams, whilst I was doing that job. I managed to get through and progressed generally through the psychiatry training scheme. I think that the area of psychiatry that interested me most from the get-go was always neuropsychiatry and liaison psychiatry, which is the sort of general hospital psychiatry. And that was very much what I found to be the most interesting. And I was fortunate in being able to obtain 2 separate jobs in liaison psychiatry in very different hospitals, one at Barts in central London, and then again at the Royal London in Whitechapel. At the end of that, though, I think I'd kind of training scheme has slightly run its course for me, and the availability of type of training that I wanted in my higher training job was quite limited. Not so much now, as I say, because the expansion of the service that is provided in East London, and the availability of consultant jobs means that there are an awful lot of subspecialty consultancies available as well, under which people train. But I went to South London and the Maudsley. They're based at the Maudsley Hospital, a very famous psychiatric hospital, and worked between there and at King's College Hospital. And I spent time working on a very busy and intense, very unwell ward that actually often doubled as an intensive care ward, or at least a step down from an intensive care ward. And I worked with the home treatment team, the crisis service and home treatment team in South, or one of them in South London, which again actually was a fabulous experience working with people from a variety of different backgrounds in the community. And it was a really fantastic experience with a great bunch of people. It was only after that I I was working in a neuropsychiatry job and a liaison psychiatry job. I'd actually been doing quite a lot of neuropsychiatry already because I'd been doing that as a special interest in the movement disorders service. We at King's had a fantastic service set up for deep brain stimulation, which is absolutely incredible intervention for Parkinson's disease and other mood disorders, looking at the neuropsychiatric considerations both pre and post op. And that allowed me to travel an awful lot for different conferences and present research. And again, I had a fabulous time. And then I finally finished up in the community mental health teams. When I got to the end of that, I think I'd been working for two community mental health teams, and CMHTs, as they're often referred to, are busy. They deal with a significant burden of clinical responsibility, but also people who are seriously unwell that we're actively trying to keep in the community, or to pass from hospital-based services to getting them back home or back into some form of community-based rehabilitation. And it's an area of the NHS that historically has always been quite overloaded. So the stresses placed upon those teams are significant. And I think actually by the end of it, that was a tough run. And at that point, one of my previous consultant professors actually approached me and asked whether or not I had anything that I particularly wanted to research. And I'd become progressively interested in the neurophysiology of pain and proposed something that I'd been muddling along in my mind based upon a lot of the reading and research that I'd done in the context, oddly enough, of Parkinson's disease, although not directly related to it. And he was interested, and we picked it up and ran with that. And so I moved back to my medical school at Barts, and I spent the next 10 years still working clinically in a chronic fatigue and pain service, still seeing patients with more general and direct neuropsychiatric problems privately, but also working full-time as an academic. It was a very busy period of time. And I did that continuously until 2017, 18, and then ultimately got examined on my MD thesis in 2001, I think, certainly during the pandemic. And then that really kind of carried me forward. But unfortunately, at the point at which my professor retired, the NHS started moving pieces on a chessboard, as it often does, and service closed, and the department closed, and the strains that were placed upon the clinical service that I was actually waiting to take over at the time was threatened with closure, and they moved us to the back of beyond, and I slightly had enough. That was what they were doing to us. So I left the NHS and continued in private practice, which, as I say, I had been doing in the background, not to quite the degree that was then demanded. And it was enormously freeing because a number of people that I'd worked with in the very long term, some of them on and off since about 2003, had been ousted from that service because they were the most experienced, the longest serving, and the most vocal about what was being done to the service. They were slightly floating around, and I was in a position to draw them in and bring them in to work with me privately as part of a firmly held multidisciplinary team. And that's really where things have continued ever since. And I haven't really looked back over the course of the past 8 years or so since I left the NHS. And that pretty much brings us up to date.
Amazing. Thank you for going into actually, it's actually really interesting to hear the full details of, like, you don't really know what your career looks like, and you just keep doing these things, and things are happening. You're like, oh, I'm going to do this. But then obviously, like you said, maybe click on closure of some services, and you go this way. It's very interesting to hear people's trajectory and how things end up. And I guess, like, since you started prior practice, like, what does your prior practice look like today compared to like when you first?
Gosh, I mean, I started, so when I've always been busy, Abbe. I've always been a worker, and I think it's one of the reasons actually that working in A&E really suited me. So it kept me out of trouble, I guess, more than anything else. But I was, even as a registrar, I was working occasional evenings and weekends in the private sector. It's referred to as an RMO, which is slightly confusing. What we used to refer to consultant psychiatrists in the terms of the Mental Health Act, but RMO refers to a resident medical officer, and they're the sort of ward-based doctor in most private hospitals in the UK. And I was doing that for a consultant colleague with whom I'd worked in a much longer term and continue to work with very closely today. And there had previously been an ECT service run there that had to be closed down because they were struggling to keep up with the regulations and the assessment exercise that the Royal College of Psychiatrists had introduced for ECT. And I'd redeveloped that, and we became a centre of excellence, in fact, a leading centre of excellence in the years that we were running it. So I'd already worked in the private sector. I wasn't seeing patients independently as a consultant, only a registrar, but when I became a consultant, that slightly confused things because I was still running that ECT service. And so I wasn't technically speaking a junior, but started seeing occasional patients independently. And it was around about that time that I then started working at the Nightingale Hospital, where we had started admitting patients as well. And in the earlier stages, I was only looking after him. But as things progressed, I began seeing private patients evenings, and it rather expanded from there. Compared to where things are now, I mean, it's chalk and cheese. I'm not there. I'm there one evening a week, but I'm there. Well, I'm either there geographically or working remotely 5 days a week. So things are very different. And the extent of the responsibility that I for patients is rather greater, just based upon the sheer number. But it's a full time endeavor.
Yeah, okay, that makes sense. And what was the biggest misconceptions that you had about growing a paramedical practice early on?
I think I probably assumed to some degree that it would be easy, that it would be something that would be organic in its own right, and grow. I think so much has changed, and I think this is probably the major misapprehension because it's difficult to predict future, but so much has changed since I became a consultant in 2010. I think that the environment of working privately has changed. I think the water has become quite muddied because it's so heavily populated by doc now, and there's been a particular explosion actually since the pandemic. I think that has not only influenced the way in which private services are accessed, but it has also influenced the involvement of insurers, who I think have become progressively more controlling in a way that I don't think they were in 2010, certainly weren't previously, both of doctors, but also patients that are their clients, with latter perhaps being more understandable. So I think that the way in which things have progressed have been largely influenced by an environment, and that's when it starts becoming kind of slightly mucky because it's a marketplace. As a doctor, I don't like that concept at all. But I think I had slightly assumed that it's something that would grow. I think partly because I'd worked with people who had been working in the private sector for 30, 40 years, and the old guard necessarily approached private in a very different way, and things did grow organically. I think that now it is rather difficult. I think primarily because of that difference, and I think particularly as a patient, and I've had to look for private consultations myself, family, that actually finding the right person I think is really difficult, because seeing the wood for the trees is almost impossible with just the sheer glut of people who are now occupying that space. So I think that's probably the major thing that changed.
Okay, yeah, that makes sense, and I agree with you for the most part on all those points. I actually wanted to ask you, like, what skills do you think private consultants need today that medical training doesn't prepare you?
I think almost anything and everything that comes to being it comes from being self-employed. I was certainly unprepared for it. I think that one tends to approach it in a slightly clumsy way to start. I think you can be too over-prepared for it. You can try to organize yourself too much for it. But I think that the kind of the general system and expectations that one has, that you need a system set up for actually thinking about how you charge people for your time. I think that there is a very limited understanding amongst doctors as to how to charge for their time, or indeed how to value it. And I'm afraid that partly comes from not only teaching and training at medical school. I think it also comes from the way in which people are, broadly speaking, treated within the NHS, that you are a commodity, but not a commodity that is often terribly valued. So when it comes to actually evaluating your own time and your skill set, I think that is very different and feels very foreign. And I kind of appreciate that sense, in one respect, that it should be alien to a doctor, because I think that it needs to be a secondary consideration. Otherwise, we're just not doing what we're doing. And if the money is at the forefront of this, I think that's very problematic. It can't, however, be ignored. It costs money to run a practice. And I think that's probably the second misapprehension, or the thing that's missing, is an understanding of how much it actually costs to run a practice and the expenses that are hidden, whether it be in terms of finding a secretary, or whether it be in terms of the change and the indemnity fees that you need to pay, and the frequency with which you need to update them in that regard. But then also the practicalities and submitting invoices to patients. And this idea of asking patients for money, again, is part of that sort of slightly alien ideal that feels very awkward. I think that beyond that, actually, also there are difficulties that one runs into. I mean, if there are any service that you're invoicing, particularly after the fact, there's always the danger that people argue about and don't want to pay. And nobody's ever taught me, even to this day, how one approaches that set of circumstance. And I'm fortunate, touch wood, it's not something that happens often, but it always it does come up from time to time, and that's quite tricky too, alongside people questioning actually how your time is. So I think that that sort of general sense of knowing how to properly value your time and evaluate from a business perspective, knowing how to deal with the logistics and the practicalities that follow that, and how that then actually places you within that overly occupied environment in which you're practicing. And although it feels foreign, trying to bring the two together has to be done. Otherwise, it's never going to work. It's never going to take.
Yeah, agreed. At what point in your consultant career did you realize I need to take my prior practice more seriously as a business, not clinic?
I think part of the problem that arises is that or certainly part of the problem that I've faced is that I necessarily occupy my time clinically. That is, I mean, it goes back to what I was saying about sort of the filthy lucre. That the financial side of it doesn't enter into my conscience when I'm seeing patients, and I'm, with a full clinic, I'm busy. And with a full clinic 5 days a week, I'm busy with a lot of patients. I'm busy with a lot of paperwork. I'm busy with a lot of trying to communicate and actually oftentimes bring a lot of other people to the table to communicate effectively and efficiently about a patient particular presentation and how best to help them and to drive their recovery forward. So having to have a one eye on a diary and be certain that there is patient throughput, that there are enough new referrals to continuously support that clinic, I think is really difficult. And I think that there is a notion sometimes that, if you've got a gap in the diary, well, that's a bit of breathing space. And I think that as doctors sometimes gratefully receive. But the problem is that has an exponential effect. And keeping an eye on that rather than being able to keep an eye directly on my clinical practice, I think it became increasingly apparent that was beginning to occupy too much bandwidth, and not really in a productive way, that it becomes something that becomes a concern and a worry. I think that generally speaking, referrals often follow a sort of a feast or famine protocol that, there are otherwise a glass and you can't fit them all in, or alternatively, there are absolutely none. And it often swings between them. And there are seasonal variations for what reasons. Just had Christmas and New Year, which is one. The summer is always difficult, everybody away. But being able to keep your eye on it, being able to keep on top of it is really hard. And it's all well and good kind of persevering with a private practice. But if there is no medicine to practice, well, the private practice isn't there. And I think I just became aware of the fact something I needed help to do something about this. And it's a problem that I know affects my colleagues as well. I think it's a problem that affects private hospitals as well, because I wanted my eyes to be on the patient and the patients that were in front of me in the moment, not the patients that were potentially going to be in front of me in 2, 3, 4 weeks time. And that I wanted to adjust that focus, my prospective focus on the future. It just wasn't constructive or helpful, just a source of concern.
Yeah. And you have a very busy private practice. Why do you think some excellent consultants and clinicians struggle privately while others are thriving?
I think that's really difficult to answer. I think it's really difficult to answer because, oftentimes being able to set up in private practice arguably requires less than obtaining a consultancy in the NHS, because you're setting up independently. I think that, you can be the best specialist in the world. I don't know that everybody is necessarily going to gel with the way that one needs to work if one is working in the private sector. And that's probably true for a great number of professions rather than medicine alone. I think that one of the difficulties that arises within that context is that you're very exposed, and you're the primary source that is responsible for what happens within that private practice, both in terms of patient throughput, but also in terms of problems that might arise. You're not going to be working within the context of having junior members of staff or allied members of staff. There is trust built around you that will actually shield you quite a lot from problems that might or might not arise. And so I think that can be quite a difficult environment in which to operate. I think that knowing that you are good at something and having the reassurance that other people agree with you on that is one step, but it doesn't necessarily mean that people outside of the medical sphere know that you are good at that. And I think it is a situation whereby one voice drowns in a crowd. So I suspect that actually not being associated with either another professional body, whether it be a hospital or a clinic, who's able to assist in letting people know that, or being a point of referral that is already well established, then you're potentially going to be quite stuck in terms of obtaining the referrals and the headspace being recognized or known of, irrespective of whether you're the best in your particular field or not. So I think that becomes tricky. And again, I think it comes back to this idea that it's something that is part of medical training, neither should it be. But I don't think it's something that anybody's ever truly exposed to working in the NHS, where we all start out. So it's a foreign land.
Yeah, I agree. I think one of the things where the majority of consultants kind of learn on the go, and lovely people who obviously been down that path a little bit before. So yeah, agreed. AI, obviously massive topic in general, and obviously I want to make sure that we talk about like how it's going to change medicine. Mm-hmm. How do you see AI changing private medical practice over the next 3 to 5?
Right. Well, my take on AI at the moment is that it's interesting, not exciting. And the reason I don't think it's exciting is I just don't think it's applicable. I've come across huge problems with it, not through my own use of it, but because of the exposure that patients have had of it. And it comes up frequently as a point of discussion that patients will undoubtedly have looked up what's wrong with them, particularly before they're going to see somebody privately and paying for it rather than being seen on the NHS. And they will have a very set idea as a consequence. I think that AI has a role to play, but a subservient one. I think that the issue, certainly at the moment, is that AI, ChatGPT, Google AI, whatever, is often wrong. And patients have been to see me and said, well, this is wrong, although the diagnosis might be right, treatment path just does not fit them. And I think that the difficulty, it's not really a difficulty, but I think where AI falls down in terms of attempting to be a clinician is that AI has the experience of an awful lot that is written online, but it has no fundamental experience in the real world. And that is something that is very difficult to feed forward or develop on a more organic basis when it also needs to be contextualized back into the person sitting in front of you. So the role that AI has to play on a directly clinical basis, I'm deeply suspicious of. And I worry, actually, I think I do think it's a significant concern that there is in some way an assumption that that might be appropriate, because I think we're a long way off that. And indeed, whether or not it'll ever be possible is another matter. Sure, Elon Musk will tell us all that it is and will be replaced by the robot, but we're not there at the moment. I think that where our AI has the potential for huge benefit is in terms of large data sets and in terms of mining data in a way that actually getting humans to do is potentially error prone and too long-winded to generate benefit in the shorter term. So I think that, machine learning in particular has been applied to large neuroimaging data sets, has generated some very interesting windows of opportunity to allow us to look at things in a slightly different way. I think that AI in the context of research on that basis is potentially invaluable, but I think that everybody tends to get a little bit carried away. And I think one of the problems with that is that developers got a little bit carried away, and it's being put in the marketplace, it's being put online, it's being put on social media, and it's being used, or it's being proposed to be used, to do more than actually I think it's ready for. But I'm not a programmer. I'm increasingly a dinosaur, having always been an early adopter, and I'm probably too old for my own good where he's concerned. But I think interesting, but not necessarily exciting just yet.
What would you tell a consultant who's just starting their practice and private work now?
Don't expect to walk into a private practice. If you think that you can walk out of an NHS job, even if you're walking out of it just at 5 o'clock before going back the next day, and that you can walk directly into a fully fledged practice in your name, you need to go back to the drawing board, because like anything, it is something that needs to be worked and something that needs to be earned. And becoming a consultant is not sufficient in its own right to determine that there will be a private practice waiting for you. I think that assumption, and I've seen it with a number of colleagues who've been kind of disappointed, and the expectation was slightly different from the reality. I think that would probably be my best advice, that forewarned is forearmed. I think that also, having a think about how private practice might actually differ from your experience of medicine, because the medicine is one side of it, and the experience is going to be very different as a consequence. I'm busier than I ever have been during my professional career, not because I have so many patients. I'm busier than I ever have been because my responsibility to those patients is far greater than it ever was in the NHS, and because the clerical work, the bureaucracy that surrounds me as a consequence of that is necessarily much, much greater. So I think that the disparity and what it is that separates what you will be doing privately from what you'll be doing in the NHS, because the medicine, fundamentally, that doesn't change, but is everything else around. And training through the NHS, you're provided with a secretary, there are systems in place, and they are, near as damn it, they're all the same. They're all the same. It doesn't matter which trust you've worked in, which hospital, and some of them may be worse than others, some of them may be better than others, but the system that is in place is all the same. And as you move from job to job, as we all do frequently during the course of our training, the one thing that doesn't change is the system that supports you doing the thing that you're trained to do. The thing that you're trained to do will not change. It's everything else surrounding that will. You are entering into a system that is different by virtue of the fact that the infrastructure, although it might be there depending upon whom you're working with or indeed working for, but the infrastructure is otherwise not there. You are free floating.
Yeah, great advice. Well, like I said, I think having that forewarning, I think will give them a bit more insight into how to prepare as well, and not just assume and then waste a lot of time and a lot of their honestly, just time and a bit of resources as well in terms of all the investments required to start private medical practice, and then half their clinics that are sitting empty. So great forewarning. And then my last question is, like, what excites you the most about the future of private medicine in the UK?
I don't know if it excites me yet, but I think it has potential too, which is that the history of medicine in the UK is dominated by the NHS over the course of the past 70 odd years. But the NHS was set up within broadly speaking, a private medical system. I think that rebalancing where things lie, I think has the potential to be quite exciting. I think the capacity potentially for private practice to exist within its own right, as I think it should, without it being seen in some ways an impingement upon the NHS. Now, in order for that to be the case, there needs to be a balance. That you can't have everybody leaving the NHS to come and work privately, because it needs to be it needs to be supported. I think it would be hard pushed to find a doctor that doesn't think that it should. But it feels at the moment, I think, a little bit too much like there is a battle line that is drawn between the two, and I just do not understand. I find that communication with primary care, who are constantly overloaded at the moment, is increasingly being supported by the British Medical Association, not to take on additional work from private consultations, so consultations with private clinicians, and that concerns me. I think that there are bridges to be rebuilt, and I think a greater understanding to be developed that actually the private sector not only complements but can assist the NHS and unburden it. And I think that this manner in which it's being posed as being so competitive is problematic. I think that the other thing that I find more exciting on a clinical basis, which is perhaps rather more established already, is the possibility for further research to be conducted in conjunction with private enterprise as a whole. That's often seen as a bit of a dirty word because it often means drug companies, but the drug companies have been involved in their own research for donkey's years, and that's not going to change. What I'm talking about is collaboration between private equity funding the research and the institutions conducting the research, as well as research being seen as being possible within research centres within the private sector. I think that one area in which that's been particularly pronounced has been in the development of the more recent Alzheimer's drug, for example, and the speed with which that's been developed has been quite exciting in terms of the trials that have been conducted. And arguably within that context, within those particular disorders, it's one of the biggest jumps, one of the biggest advances that we've seen, having previously had medicines that perhaps keep things within a status quo and slow decline. We're actually seeing things that potentially could halt it. So that's enormous. And I think that, we've seen this in a variety of different settings. It's happening, I think, with greater frequency. The major research councils actually increasingly have started to encourage it. And I think that research, rather than just clinical medicine, I think has the potential to prove a very exciting breeding ground for future work to be conducted within the UK, within the private sector, but conjointly with the more typical medical institutions within the public sector, not just the NHS, but also the universities, who are also absolutely key because it's where the academic figurehead tend to be. So I think that's probably the area that I think the private sector as a whole within the context presents the greatest or the most exciting opportunities moving forward.
Yeah, I agreed. I think that'll happen. There's so many other things I think will happen as well, like specialties, specialists, consult specialists coming together. So brick and mortar sort of clinics, kind of like we have dental clinics, obviously probably funded by some private equity, and then having to go through the process CQC. But I think that'll be maybe the biggest competition. Hospitals, for instance, and have 5 cardiologists come together, start their own cardiology clinic, perhaps with a theatre, if they have got the right funding. So yeah, I think very excited to see what happens. But yeah, awesome. That was all my questions. I think you've given a lot of insightful and valuable information to other consultants and people who are looking to start a private practice as well. So I think they would appreciate the conversation. And obviously, therefore, if they have anything related to your specialty, they can go ahead and refer the patients to you as well. I'm going to see if somebody's obviously